All right, well, we're going to let some folks in here. I can see that folks are joining the room. So thank you so much for joining us this evening for our session on systemic sarcoidosis. My name is Mindy Buchanan. I'm the Director of Patient Programs with the Foundation for Sarcoidosis Research. I want to first give a thank you to our sponsors, Boehringer Ingelheim, for their support of our educational webinar series. And then it is my pleasure to introduce you to Dr. Michelle Sharp from Johns Hopkins University. Welcome, Dr. Sharp.
Thank you. Should we give everyone a few more minutes or?
Oh, I think we can get started. And just so everyone knows, there's a couple things. One, this session is recorded, so you will be getting it in an email and it will be available on our YouTube after this. Additionally, if you have questions, please put them in the Q&A. The chat function has been turned off, although I may chat things to you as the audience if I need to, including things like links to things that Dr. Sharp is referencing. So I think we're good to go.
All right, well, thank you all for having me. As Mindy mentioned, I'm Michelle Sharp. I'm an assistant professor of medicine at Johns Hopkins University School of Medicine, and I'm also one of the co-directors with Dr. Chen of the Johns Hopkins Sarcoidosis Program. And so today we're going to talk about systemic sarcoidosis. Thank you all for those individuals who put in the chat or in the response some questions. I've tried to weave some of the answers into the talk today. And then we'll, of course, have plenty of time at the end for questions. So let's talk about sarcoidosis first. So sarcoidosis is a disease that's characterized by non-caseating granulomatous inflammation. And what I'm showing you here is a granuloma. And I show you this mainly, and we're going to talk a little bit more about what a granuloma is to bring up that a lot of individuals with sarcoidosis have a biopsy. And they have a biopsy that comes back with non-caseating granulomatous inflammation, and they're told, you have sarcoidosis. And it is important both for physicians and for patients to know that sarcoidosis is a diagnosis of exclusion. There are quite a few things that can cause this type of inflammation. And so as a sarcoidosis doctor, it's my job to make sure it's not something else before we call it sarcoidosis. So let's talk about what is a granuloma. So it is a compact collection of mature cells in your body. So it can be lymphocytes, it can be polymorphic nuclear cells, can be part of it. The collection is macrophages and or epithelial cells with these other type of cells associated. And then you can also have something called necrosis, which I'm showing you a picture of here. And that just is really a breakdown of things in the middle. And again, this is a little bit of the science behind it, but the most important thing to understand about a granuloma is that it forms around things that are poorly soluble or insoluble, which means that they can't be fully taken up. And it is your body's way of trying to protect itself from something. So I like to think of it as your body's walling something off that shouldn't be there to try to protect itself. And so there are a lot of different causes of granulomas. One of the causes is just foreign material. So it's not anything that your immune system is necessarily reacting to. It's just something that's foreign that shouldn't be there. And then the poorly soluble things are what cause the granulomatous inflammation. And again, it is a normal response of your immune system in certain cases, like infections, where your body is trying to protect itself. And so things like mycobacterium or tuberculosis and fungal infections. And then you'll see on the list, there's also non-infectious causes. And sarcoidosis is not the only non-infectious cause of granulomas. So that was just a general overview of kind of what granulomatous inflammation is and what granulomas are. Let's talk a little bit about sarcoidosis epidemiology. And I will say this with a caveat, we don't know 100% the true epidemiology in the United States. These are, it's challenging given our healthcare system to know exact numbers, but there's a range from 49 to 141 per 100,000. And in Canada, where there's a national healthcare system, they reported out in the literature 126 per 100,000 individuals. So it is a rare disease, but I would argue it's not as rare as we probably think it is. It is 2 to 5 times more frequent in Black individuals compared to white individuals. And its mortality ranges from less than 1% to approximately 6%, with higher mortality among those individuals with chronic disease. And then one of the big questions that I always get asked is, if I have sarcoidosis, what does that mean for my family? And in the literature, we've seen that there's about a 5-fold increased risk of sarcoidosis in relatives. Although in general, it's a pretty rare disease, it does increase your risk if you have a relative. So next I wanted to move to a case presentation. And so we're going to talk about this case, and it's going to be the way that we frame the next part of the talk. And it's a 34-year-old patient who has shortness of breath and mediastinal lymphadenopathy, which is swelling of the lymph nodes in the chest, who comes into clinic for evaluation. And so every time I meet a new patient in clinic, these are the 3 questions that we go over together. First is, do I think you have sarcoidosis, or is this case presentation consistent with sarcoidosis? And then the second question is, if yes, what organs are involved? And this is a talk about systemic sarcoidosis. We're going to go through all the different organs that you can have involved. And then the third question is, should I start treatment? And if so, how much? So we're going to start with, is this sarcoidosis? So we've gone over a little bit about granulomatous inflammation. And I just wanted to also remind you again that there are a lot of different things that can cause granulomas and granulomatous inflammation. And I love this from 2017, the A to Z of things that can cause granulomatous inflammation. And so the first, again, is trying to rule out other things and make sure that's not what's causing the inflammation or the clinical scenario. And then we usually talk through what is sarcoidosis. And I think this disease is so tough because we really don't know exactly the cause. And I can't tell you 100% this is why you have sarcoidosis. But I'm going to give you the general overview of what we do know. There is a trigger, and for some, we think likely there are multiple triggers, and this is a big debate of what the trigger is in our field. But potentially bacteria, there's some evidence for bacteria that lives in your skin, mycobacterium, organic agents, maybe inorganic agents. We aren't certain, but what we do know is that individuals who develop sarcoidosis likely are exposed to something in the environment, a trigger. And it's the relationship between the environment and who they are and their immune system that causes this immune response to create granulomatous inflammation. And the other very important thing to note is that even after the thing that started it all is gone, the trigger is gone, the immune system can actually continue the inflammation. And this is called feed-forward amplification. But it's important to know that your trigger may have been years ago, but it set the immune system off to cause this ongoing inflammation. So in general, as a field, we do not believe that sarcoidosis is autoimmune. We believe that it is your body trying to respond to a trigger to protect yourself. But in doing so, the immune system is over-responding and causing this inflammation that subsequently in some individuals can lead to organ dysfunction. So one of the other big questions that always comes up when we're talking about, is this sarcoidosis, is, am I going to go into remission, or is this going to be a chronic disease? And so I wanted to go through this together with a couple of different scenarios and also to explain or help demonstrate the differences that can happen in sarcoidosis and the fact that not one patient with sarcoidosis is the same as another. And that's because of a couple of variables. And the first is So I'm going to orient you to this real quick. On our y-axis here, we have sarcoidosis inflammation, and the x-axis at the bottom over time. And so this is time. And then the dotted line that I hope is coming up clearly for everyone is clinical symptoms. And so this blue arrow is the first patient that I wanted to talk through. And so they have inflammation over time growing, but then it goes away on its own and they go into remission. And this is a patient that I would likely not meet because they never actually became clinically symptomatic. And so this might be a patient who gets in a car accident and has a chest x-ray and is found to have swollen lymph nodes, but never had symptoms and has their disease is not active. Or they may never even know that they had sarcoidosis. It may never get picked up. Now let's talk about the next patient. And so you'll notice this patient's arrow, their inflammation is much quicker in terms of time. It grows much faster. And they are clinically symptomatic. And this patient, let's just, as an example, comes to see me in clinic. And so we decide to treat them as a team, and their inflammation goes away. And luckily, it never comes back. And so this individual has, we would say, is likely gone into remission. And then let's talk about the third patient. And so again, you'll notice that each person, each arrow or color is supposed to demonstrate a different patient. Their amount and rate of inflammation growth is a little bit different. And that's part of why sarcoidosis is so interesting and also challenging, is that each patient's inflammation might grow at a different rate, but they become symptomatic and they seek medical care. And let's say we start treatment as a team collaboratively with the patient. Their inflammation improves, their symptoms resolve. We then stop or reduce treatment. And unfortunately, the inflammation comes back and they have symptoms again. This would be an example of an individual who has not gone into remission. Now, let's talk about in general, and I think this came up in the questions. If you're going to go into remission, and this is what I call the 95% rule, not the 100% rule, but the likelihood is that you'll go into remission in the first 2 to 3 years. And so if this individual here, they develop symptoms again, and let's say we're at year 1, likely we would consider treating them again to get their clinical symptoms under control and reduce their inflammation. And then usually, and again, you should talk with your local providers, we stop treatment or reduce treatment because we're always trying to find the lowest level of treatment that will control the inflammation to try to minimize the side effects. And if it continues to come back at a certain point, we often will say, this is your treatment dose, and that we don't think that you've gone into remission or are likely to go into remission. Now, this is another example of someone who, again, an individual who doesn't get treatment versus treatment. And then, once we get it under control, we either lower treatment or we stop treatment depending on the treatment that we're on. And then the inflammation comes back, we do it again, and it comes back over time. If we allow this inflammation to continue, what will happen is that you'll develop scar or fibrosis. And that is the number one thing that in sarcoidosis we are trying to prevent, because we can't reverse scar. We can control or reduce inflammation, but we unfortunately are not able to reverse the scar. And then, I'm sorry, this didn't come up as well as I'd like. There's another individual who asked about burnt out sarcoidosis. And I, in general, don't like that terminology because I don't know if it ever burns itself out. But what I think may happen is we have some individuals who their inflammation is very, very slow growing. And they get treatment and stop treatment. And this might take 10, 15, 20 years to develop. And it comes back, and while they may not be in remission, they still have low level inflammation, but we can't detect it. And so they may appear to be in remission. And I usually follow individuals off treatment for about 3 years before I'm willing to say I think that they're in remission. And even then, I give them a pep talk at the end of 3 years that this doesn't mean our relationship has to end. If anything comes up, if you have any new or concerning symptoms, I'm always a phone call away. Because I'm always worried about the individual that may still have low level inflammation in the background, and I'm not able to detect it, and they don't have symptoms. And so I think this may be what some individuals call burnt out sarcoidosis. Again, not my favorite terminology. So that was how I approach, is this sarcoidosis? And again, just to review, we don't know what causes sarcoidosis. Likely there are multiple different triggers. It's likely an interaction between who the individual is in terms of their immune system and their genes and their interaction with the environment or the trigger. It is an immune response to something that causes the granulomatous inflammation. And even after the trigger or the thing that set the immune system off, it's still there. Or in some individuals, the immune system can continue to form inflammation. About 50% of individuals will go into remission. I can't predict the 50% that's going to go into remission. There are some things that make it more likely to go in remission and some things that make it less likely. In general, the more organs you have involved, the less likely you're going to go into remission, but that's a general rule. There's not a ton of data behind that. And then if you have acute sarcoidosis, which we'll talk about next, which is Lofgren syndrome, that often is thought to have a better chance of going into remission. Those individuals who go into remission, what they do is they flip the switch and they put their immune system back to normal. The individuals who don't go into remission, those are individuals who are likely going to need treatment if they have organ dysfunction to control the level of inflammation so that it doesn't cause organ dysfunction. All right, next, let's talk about if you have sarcoidosis, what organs are involved. So this is one of my favorite diagrams, and it does a really good job of telling us the percentages that you see are the most common, or the percent of time that that organ is involved in terms of sarcoidosis. So you'll see that the lungs are number one, and that's why most sarcoidosis physicians in general are lung doctors or pulmonary doctors. 90% of individuals have it in their lungs. If you don't have it in your lungs, but you have it elsewhere, it doesn't mean that you don't have sarcoidosis. It just means it's more common that you have it in your lungs. So let's start head to toe. And in general, actually, before we start head to toe, I think one of the other really important things to know about organ involvement is that we don't believe sarcoidosis spreads. So we believe that it affects each person differently, and it can affect all these different organs. But we believe for the individual person that it sets up shop in certain locations. Now, we may not always be able to detect it there. And I want you to think back to the slide where we talked about clinical symptoms. We may not know if it's in your heart right away. We may not know if it's on your skin. And what we do is we follow you over time and we always ask a lot of questions. And most of my patients know there's this part of our visit where I go through a whole list of questions because as a sarcoidosis doctor, you're always trying to make sure you're not missing another organ and you're not missing something. But again, one of the most important things is we don't think it spreads. We think it sets up shop in each organ, or in each person in certain organs. Each person's different, but we do know that we can't always detect it right away until it becomes clinically significant. So let's talk through the brain or the nervous system. So things that I screen every patient for include headaches. We talk about numbness and tingling. weakness on one side or the other. And those are things that I'm trying to pick up on whether I should be worried and go further into whether they have neurologic involvement. You can have neurologic involvement by having a seizure. Some individuals from a symptom or clinical manifestation can have a facial weakness where one side of their face doesn't work as well as the other. You can have vision changes from the brain itself, and we're going to talk about the eyes soon. You can actually have hearing loss, and I've had one patient wake up and acutely not be able to hear out of one ear. And that's actually neurologic involvement because you have a nerve that controls your hearing that sarcoidosis can affect. Um, and then you can have spinal cord, which, this one is pointing to the brain, but the spinal cord also matters and is important. And you can have weakness in one leg or the other. You can have pain. And numbness and tingling from a nervous system can also be small fiber neuropathy, which is a little bit different than general neurosarcoidosis and can respond differently, but that can be pain and numbness and tingling. Next, let's talk about the eyes. So in my program or my practice, we ask our patients to get a yearly eye exam or more frequent if they have eye symptoms. So it occurs in the eyes 10 to 50% of the time, but part of the problem with the eyes is that you may not know it, and it can be clinically asymptomatic. So you can have inflammation in your eyes but never feel symptoms. And that's why we ask our patients to go to the eye doctor once a year, just for screening to make sure we're not missing anything. But I screen my patients when I see them to ask if they have any pain in their eyes, if they see any bright lights in their vision. In general, those are two pretty good screening questions that if those aren't happening, then we stick with our yearly eye exam. If either of those are happening, then I request that they see an eye doctor sooner. So lungs, we're just going to move down the body. So lungs are, again, the most common organ involved. General symptoms are shortness of breath, cough, are the two big ones that I have in terms of presentation. We usually are the first people and when I say we, lung doctors are often the first individuals who meet a patient with sarcoidosis in terms of sarcoidosis management, in my experience. And so those are usually either symptoms that they've had or are currently having. I'm trying to think of any other particular things to talk through. We're going to talk about testing that I might order if you have lung involvement, but really shortness of breath and cough are the main two. The cardiovascular, the heart can be affected in two big ways. One is the electrical part of the heart. So the heart has an electrical activity, and you can get a heart block where the activity doesn't work in synchrony or together as much anymore. You can also have bad rhythms that make you dizzy and pass out. Patients can often experience chest pain, which I think can sometimes be pulmonary related or cardiac related, or even small fiber neuropathy or muscle involvement. So chest pain can be a bit difficult to ascertain, but is a question that I ask and something that helps us figure out what else we need to do and make sure we don't miss anything else in terms of cardiac screening. And then you can have palpitations, which is where your heart skips beats or is irregular. And that is a sign that the heart system might be involved and often triggers us to do a further workup. Let's go to we'll stick with the right side of this picture and talk about bones and joints. And so you can have sarcoidosis inflammation of the bones itself, and then you can have joint pain. Joint pain, if it's Lofgren syndrome, actually can be bilateral, or which means both sides of the ankles can get very, very painful. In general, if it's not acute sarcoidosis, often we'll see pain in the hands and the feet, and then traditionally the smaller joints, but I will tell you, I've had patients have pain in all sorts of joints. And so having joint pain is important to tell your doctor about. And it's one of the things we're going to talk about with treatment that I often ask patients to monitor and see if it gets better with treatment, or some of our treatments can have side effects if individuals think it's getting worse with treatment. Let's go back to the other side and talk about gastrointestinal system. And so this is extremely rare. I have very few patients in my practice who have gastrointestinal or stomach and intestine involvement. It's often, if we do find it, it's biopsy proven. And it traditionally responds in the same way as the other organs. Under that is hepatic, which that is the liver. And you'll see that actually quite a high percentage of individuals with sarcoidosis have it in their liver. We usually do blood tests to screen for this, or you can have abdominal pain because if the liver gets a lot of inflammation, it can stretch or get bigger, and that can cause a stretch of the wrapping around the liver and can be painful. And the same with the spleen, which is on the other side of the abdomen. Those two traditionally go together. And then next is kidneys. The kidneys are actually rarely involved in sarcoidosis, or not rarely, but less frequently, but can have inflammation involving the kidneys. The muscles themselves can have inflammation, and I have several patients who can tell me when their inflammation is acting up because they feel it in their muscles, particularly in their legs, but it can affect pretty much any muscle system. And then the skin. The skin is tough because the skin can have so many different manifestations. And we have a dermatologist that we work with closely just because it's so challenging as a general sarcoidosis specialist to know all the different, whether some of the different skin findings are consistent with sarcoidosis or something else. One of the most commonly described findings is something called lupus pernio, where you get nodules under your eyes, around your nose. You can actually get them behind your ears and on the back of your neck. And it can be a very tough thing to treat, and it's a specific type of sarcoidosis skin involvement. But I have seen just dark spots on the face or red spots on the face. You can have scalp involvement, which is can be challenging because it also can be associated with hair loss. And so the skin can really manifest in a lot of different ways. There was a question about vitamin D and calcium. And so I wanted to review this. This is something that I often think of that goes along with the bone and the kidney involvement or the renal involvement. And so I'm showing you a little bit of an equation, but it helps me because I'm a visual person. There are a couple of different types of vitamin D in the body. There's 25 vitamin D, which is what everybody else who's not a sarcoidosis doctor will measure. If you go to another doctor, that's the vitamin D they'll measure. And then there's 125, which is actually the active form of vitamin D. And what I'm showing you here in the middle is our granuloma. And some people, not everybody with sarcoidosis, have a special enzyme on their granulomas that convert the 25 vitamin D to the 125 vitamin D. Now, it's not important that you know the granuloma enzyme. What's important to know is that if this is happening in you, because you have active sarcoidosis inflammation, and somebody just measures your 25 vitamin D, it will look like it's low, but that's not really the situation. It's only low because your granulomas have this special enzyme and are pushing it to the 125 vitamin D, which is actually the active form. And this is actually elevated. And if somebody doesn't measure both of these and only measures the 25, they'll say, oh, you have vitamin D deficiency, and they'll give you vitamin D. And if this process is active in you or in the individual with sarcoidosis, it will actually cause a problem, because what it will do is it'll give more 25 vitamin D, which will then go to more 125 vitamin D, which will make this go even higher. And as a result, you can have elevated calcium levels. Elevated calcium can cause problems, including kidney damage. It can also cause kidney stones, and you can have bone pain, and you can have a lot of different things that can happen from having too much calcium in your body. And so I am very, very protective of any patient of mine taking vitamin D supplementation. We have patients who definitely need it. But the important thing is, if anyone of my patients gets it, the things that I require is that they have to make sure we measure the 25 and the 125 in addition to a calcium level. And there's another hormone that helps regulate all of this. If that is truly showing that you have vitamin D deficiency, then I'm okay with starting supplementation or having someone take it. But if I don't have all that information and all I have is a 25 vitamin D low, I'm not comfortable with that individual being put on vitamin D supplementation until we measure the other ones. And it's because in sarcoidosis, vitamin D can hurt some individuals if this process is active. Again, it's not active in every patient. And if you're able to get the disease under control and you control the inflammation, then you don't have a granuloma causing this process. And it would be safer to take vitamin D. So next, let's talk about evaluation. And this is a slide that I use to teach with the residents and the fellows. And so it's not meant to be all inclusive, but it's meant to show you that in every new patient that I meet, I do symptoms, and there's some baseline testing that I do, and then there's additional testing that I do pending what their symptoms are. And so in general, if someone, I'm a pulmonologist, so I have a little bit of a different practice pattern because I see mainly pulmonary, well, I see all types of sarcoidosis, but a lot of the referrals are pulmonary referrals. And so we usually do some form of chest imaging and lung function tests. And the cardiac, or for a cardiac screening, usually every patient gets an EKG or already has had an EKG, which is looking at the electrical rhythm in the heart. And then there are other cardiac testing that we might do depending on symptoms. And we talked through when we were talking about all the different manifestations of sarcoidosis, what symptoms might prompt further evaluation. And then we do blood work looking at kidney function or renal function and liver function. We've talked through the vitamin D, calcium. And then we look at the bone marrow, which means that we look at the white blood cells, the red blood cells, and then I ask everyone to get an eye exam. So again, sarcoidosis can affect, I'm going to go back to the little guy, can affect pretty much any organ. And not even all the organs are listed here. There are other extremely rare manifestations that I have seen once or twice in my practice, including testicular involvement, appendix involvement, tonsillar involvement. We didn't talk about parotid gland involvement. So there are additional involvement, but it's important to know that it can affect almost any part of your body. We don't believe it spreads. We believe it sets up shop in different people in different locations, and that we may not always be able to detect it right away, which is why it's important to always be aware of your body and your symptoms, and make sure your care providers are also aware of any new symptoms. So now let's talk about, should I start treatment, and if so, how much? So this is a diagram that I am very fortunate some of our patients helped me put together from our patient advisory board. But this is in general how I think about treatment. And I'm not going to go into the nuances of treatment, but as most of you know, steroids or prednisone are fixed-line therapy in sarcoidosis. And I know most of you also know that steroids are not a great drug. I often like to say it's my frenemy. It's 100% effective. I have yet to meet a patient it wasn't effective in. But the problem is whether or not you can tolerate the dose you need to control your inflammation, because some of the higher doses have significant side effects, as most of you know. And so it's a balance of treating the inflammation, but not making you overall worse from the significant side effects. Traditionally, and in the guidelines, if you need more than 10 milligrams of prednisone to control your inflammation, you would start something called a steroid sparing agent. And that is what's in the gray boxes. I've listed the main ones that we use in our practice as second line treatment, which include methotrexate, mycophenolate or Cellcept, and azathioprine. There are different reasons why you might choose one or the other, and it really should be a discussion between the provider and the patient. And then often if those medications don't work or there's a side effect or intolerance, we would go to third line therapy, which I've listed there. And there are sometimes in treatments where maybe the third line therapy would be used earlier. And again, that's just depending on the clinical situation. There's also other additional treatment options. I've listed some of the topical ones. So for cutaneous sarcoidosis, if you're not having active involvement, you may have cutaneous involvement, you may have lung involvement, but if your lungs aren't causing you any bad symptoms, if your lung function's stable, if your imaging and all of that is stable, we might not start you on systemic treatment and might try to treat your skin topically. And so again, it's a balance depending on which organs are involved of what our treatment plan would be. And this is kind of an overview. And again, this is a lot of information, but I wanted to kind of give you the fact that there's a different range depending on the organ. And the number one rule that we use in our practice is that we treat if there's organ dysfunction and symptoms. We do, of course, take into account symptoms, but the main thing is we're trying to avoid the scarring of the lungs, the heart, the brain. Prednisone, as I mentioned, is our first line treatment. For lungs, this is not for the 100% rule, but I would again say the 95% rule. Most individuals who have pulmonary involvement and just pulmonary involvement, we can often control their disease with 7.5 milligrams to 15 milligrams of prednisone. And I put that in there because I know a lot of patients that I meet for the first time are unfortunately put on just super high doses of steroids for a long time and have really bad side effects. And so it can be a challenge and a discussion of finding a dose that they're willing to take that can control their inflammation. And luckily with steroids, traditionally, the lower the dose, the less side effects. And for the lungs, you often don't need as high of a dose. For the heart and the brain and the eyes, we sometimes need much higher doses. And that's partially because, or not partially, it's mainly that there's not a lot of window room for error. If you don't control inflammation in the brain, it can cause damage much quicker than not controlling inflammation completely in the lungs. And our real goal is to prevent the organ dysfunction and the clinical symptoms. And then I put, for cough, there are some different regimens that may not treat the underlying inflammation if that's not causing active organ dysfunction, but you're having symptoms that we do. And then again, we've talked through the steroid sparing agents. For the sake of time, I might go through this quickly. This is one of my favorite trials in terms of treatment. And it also helps demonstrate why sarcoidosis research is really hard. They enrolled 183 people and they observed them all for 6 months. And actually 58 got better on their own. And so that's why it's a little bit hard to do some of these treatment trials, because we know that there's a subset of individuals who will go into remission on their own and never need treatment. 33 got worse in that 6 months and required treatment. And 58 didn't get better, but didn't get worse. And they randomized them to daily treatment versus treating them if they had symptoms. And this was treatment with steroids. And they actually followed them for 5 years. And what they found is that daily treatment was actually better than intermittent treatment in terms of lung function results. And so just taking us back to our case presentation of this individual, we would evaluate and make sure that we've ruled out other causes of potential granulomatous inflammation, presuming that they were found to have granulomatous inflammation. Um, I would, if this patient hadn't had a biopsy, I probably would send them for a bronchoscopy to try to determine if sarcoidosis was what we were dealing with and rule out infections, which a bronchoscopy can often help do. And then we would talk through screening of what other organs might be involved, and then we'd talk about treatment depending on what we found. I wanted to do just a quick, we've talked a little bit about cardiac sarcoidosis, but there were several questions about it. The big things that I worry about in cardiac sarcoidosis are the bad rhythms, which is you can feel palpitations, which is where your heart's racing or skipping beats. I worry about heart block, where the two parts of the rhythm don't connect well to one another. That can often make you dizzy or feel really bad and pass out. And then cardiomyopathy, which is heart failure that you can get from sarcoidosis inflammation. And then sudden cardiac death is a risk of cardiac sarcoidosis, which is often why some patients, if they have bad rhythms, will get a defibrillator placed. Um, it's not. We think that cardiac involvement. It's reported to be 3 to 5% of individuals in their initial presentation, but it's actually probably more common in general. And I put some autopsy prevalences there, and it seems to be becoming a little bit more common or more recognized recently. And so something to be aware of. And then I just put a quick or a slide about fatigue, because this was also a lot of the questions. And I will be upfront and honest, it is a big challenge in sarcoidosis. And I think part of it is that it doesn't often respond to usual sarcoidosis treatment. So I can't usually put somebody on prednisone and make their fatigue go away in the same way that I can help make their cough go away. One of the best things that I've seen be helpful is physical activity. Although I put in there a caveat, it's important to note first that you shouldn't overdo it. I like to tell patients no running a marathon the first day or running a sprint. It's really slowly working up your physical activity and recognizing that actually in the first few weeks, even up to a month after you start doing physical activity, it can worsen your fatigue, and you've got to stick with it. And if you stick with it and get through that first month, it often will make it much better. And so it's just slowly adding it a little bit every day and making sure you don't overdo it. Nutrition, I think good nutrition is always a great thing. And we often will refer individuals to nutritionists. And then a diary. I think this is helpful to know. I think a diary in general, if you have sarcoidosis, is a great idea, but it's helpful to try to see if there's any pattern to worsening your fatigue or improving it. And then there are some medicines, if those things don't work, that some individuals can take. In general, my advice for patients is to keep a diary of symptoms and side effects. And I'm giving you that advice as I've learned that from other patients. And it is really helpful for me as their doctor to know what symptoms we're dealing with, and especially when we start treatment, what gets better, what doesn't, and then if they're on treatment, what side effects they develop on treatment, to help us figure out how to balance things. I think you should discuss any new symptoms or concerns with your sarcoidosis doctors or providers and your primary care doctor. So my rule with my patients is I want to know anything new that happens. I want to know if you wake up and can't hear out of one ear, because no one will look at you with the lens of sarcoidosis in the same way that I will. But at the same time, you're entitled to normal, what I call normal people disease. So you're entitled to have osteoarthritis of your knee. You're entitled, and we always watch for other things like chest pain doesn't necessarily mean you have sarcoidosis. It could mean that you have coronary artery disease. And so we don't want to miss those things by attributing them to sarcoidosis. And then in general, this is actually advice for myself too, is one day at a time. We are living in rough times, and I think also having a chronic disease, this is not easy, and try to take it one day at a time. Overall, again, not all granulomas are sarcoidosis. Organ involvement, we always need to assess it and be on the lookout for other organs that might be involved that we didn't know about in the beginning. And we always treat if there's organ dysfunction. And with that, I will take questions. I see there's coming.
Thank you, Dr. Sharp. This is great. We do have a bunch of questions. We have some questions that people submitted in advance. And we also have some questions that people submitted throughout your presentation. So do you want to start with some of the advanced questions, or where do you want to start?
Dealer's choice. I will do whichever.
Okay. Well, let's start. Let's go ahead and start with some of the folks that have submitted questions right now, because it's most salient here. So we do have a question about, I think it was actually at the moment of your presentation. The first question there is, what if the sarcoidosis is necrotic versus non-casating pathophysiology?
We can go back, if it's all right. I'll take you real
Yeah.
quick back to that slide. So the necrosis is at the bottom. This is very, very, very atypical for sarcoidosis. And in fact, what I'm showing you is extremely atypical. If you have what's called necrosis and lots of necrosis, not just focal areas of necrosis, then we often are more worried about an infection. Versus in sarcoidosis, there is traditionally it's called non-caseating or non-necrotic inflammation. And so that helps me in this part go one way or the other based on the biopsy. When there's a question, and actually I had a patient that I saw recently who their pathology read necrotizing granulomatous inflammation, but I went back and had our pathologist look at it, and it was just a little focal points, and actually it was more consistent with sarcoidosis and less of an infection. And so if there's ever a question, it's always a good idea to ask your team to maybe look back at it. But again, it's one of those things that it helps us think more infection versus sarcoidosis.
Thank you. Now let's switch over to one of the questions that were submitted in advance. And I know that you touched on this a little bit, but this is obviously a very hot topic for folks. And so one of the questions is this a death sentence? And I know you did talk about that a little bit, but this is a question that we often get in sarcoidosis spaces.
Yeah, it is not. And I think that is, we can control the disease. Unfortunately, we can't put it into remission, but we have lots of options, and there have been very challenging cases that I have worked with and patients that have struggled with the disease, but in no case have I never been able to get the disease under control with time. And part of that time part, which is challenging, is that everybody is different, and not everybody responds to either the same dose of steroids or the same other steroid sparing agents that we call. They're not effective in everyone, and I can't tell you ahead of time which one it's going to be effective in. But if I can control your inflammation, which I am certain that we are able to do that as physicians with enough treatment and working together, that we should be able to avoid the organ damage that is what's life-threatening. And so it is really not a death sentence. I don't have favorite patients, but if I did, I have a patient that I am very, very fond of, who has had this disease for 49 years and living strong. And she lives and has it as a kind of side note, but has lived a long and successful life. And I do not think sarcoidosis will be the reason that her life ends. And we've been able to find the right dose for her over time.
Thank you. And that is, thank you. Yeah, thank you very much for that, because it is a common question. We get a lot. I get a lot of emails from folks who are newly diagnosed as well. So we definitely appreciate that. Another question submitted tonight is, well, and this is a hot topic as well. I was diagnosed a few months after getting my COVID vaccine. Could this have been the trigger?
So that is a good question. So I don't, we don't, uh, so the science is not completely there. I will tell you my personal opinion and experience. So the COVID vaccines are immunogenic. So what that means is that the vaccines, or any vaccine actually, the goal of the vaccine is to stimulate your immune system to respond so that you build protection if you see that virus or shingles, the pneumonia vaccine, all of that is trying to give your immune system protection. And so it stimulates your immune system to respond. Sarcoidosis is a disease of the immune system and the immune system being overactive. And so you're getting a little extra stimulation. I will say I have not met a person who was diagnosed and we thought the vaccine was a trigger, but I have had patients, specifically patients with neurosarcoidosis, who've had an acute increase in their symptoms following the vaccine, but then it goes away, usually within about 3 weeks. So we've seen some, especially personally, my patient practice has been some small fiber neuropathy that it has stimulated some increased pain and then it's settled back down. So my suspicion would be that that individual may have had sarcoidosis inflammation that was not clinically symptomatic. On my graph, it hadn't quite reached the tipping point, and maybe the stimulation of the immune system could have reached that tipping point, but that is a hypothesis.
Thank you. So how can the younger generation find out early if they have sarcoidosis or will develop it?
So this is, I touched on it a little bit, but a huge question that I get when I first meet people is, are my kids going to get this? Or is my brother going to get this? And the question or the answer is, I'm not certain. If, in terms of, it's a rather rare disease. It is more common if you as an individual have it that your relatives will get it, but it is not a guarantee. And so my advice is to make sure that your relatives know that you have sarcoidosis. So if they develop a cough or they develop any new symptom that is abnormal, they make sure they tell their physicians or their care team that they have a family member with sarcoidosis, and make sure you advocate or help them advocate for themselves to be evaluated, and make sure their team is looking at them with a lens of sarcoidosis.
Thanks. So we'll add another one here from the group tonight. So how many years of methotrexate, hydroxychloroquine, and Enbrel are okay, and when might these become harmful?
So methotrexate, my general practice is if you're on methotrexate for 8 to 10 years, you get to meet a liver doctor. And we usually do I don't do it because it's not my specialty, but I have individuals meet with a hepatologist to evaluate whether we can continue methotrexate. There are specific tests that they can do looking at the scarring of the liver and making sure the liver is safe enough to stay on it. And I've had patients on it for decades. As long as that continues to be fine, it's safe. I think the next one was Plaquenil or hydroxychloroquine. So the big risk in that, and what my patients and I talk through when I prescribe that, is that 1 in 5,000 individuals on Plaquenil can have eye damage. The risk is, the longer you're on it, the bigger the risk, but it is something that is detected, that you can pick up very early. And so it's important that if you're on that medicine, you get special eye doctor testing to make sure that your retina, which is the back, I think it's, yeah, the back of your eye. I'm trying to remember, it's OCT, but don't quote me on that. It's an eye test that can look at the back of the eye to make sure there's no damage. And as long as that's safe, then you can stay on the medication. And we always work with our eye doctors because our patients see them every year. And we require the every year Plaquenil screening to tell us whether it's okay to keep on it. And then I think the other one was Enbrel. I actually can't speak to that one quite as well because we don't traditionally use that one in our practice. But I will say I use TNF alpha inhibition, like Remicade or Humira, and those are fine as long as you're doing your appropriate screening labs and everything looks safe.
Thank you. So as we're mindful of time, we have just 2 minutes, and I wanted to actually give this question because it's actually quite a big one, and it's a multifaceted question. So we're going to end on this one. So, and it's definitely one we get asked a lot. What strategies do you suggest for dealing with the fact that this is a systemic disease, but medical practitioners are trained to divide symptoms into treatments, into organ systems, and to not think systemically? And how do patients get the help they need across organ systems when practitioners may not think that way?
That is a very good question. I will admit that I don't have a perfect answer. What we've tried to do in our program is build a multidisciplinary team. And I think the most important thing is finding a group of doctors who is willing to work together and communicate with each other. The most important thing, though, is I think you need a quarterback. And in our program, the pulmonary team is the quarterback, and so we often are the people who or the physician and care team that sees the patients more frequently, and we call in for help when we need cardiac involvement, when we need neurologic help, ophthalmology involvement. And I know that not every program out there has that, but I think trying to find one doctor, even if it's your primary care doctor, that you are close with and that can help you coordinate care between everybody is really important. I think also trying to, if you're able to, which may not be possible at all times, trying to keep everybody in the same system. It is actually really challenging to get some records from other systems. And I know the system, like I am on the inside. And even at times I struggle to get other people to communicate with me. Um, and then I think also advocating for yourself and trying to insist that people talk to each other. And I have a couple of patients who do a really good job at this. And I try to call X, Y, and Z, and I miss them. And then, but every time I talk to the patient, they're like, have you talked to them? And it's actually been really great because it pushes everybody to make sure we connect. And it's actually got a lot of physician cell phone numbers now. Because when you try to connect through offices, it can be challenging. And so you just want to make sure you have a team of people who are talking. Um, and I also think that goes back to making sure it is a systemic disease that you're not missing an organ involvement. And so having a close communication with a primary care provider and a sarcoidosis specialist is also really important because being able to say, hey, I don't think that's me. And I often will type in and say, please run it by your primary care doctor. And then I'll reach out to the primary care doctor and say, this is why I'm not sure it's me. Will you let me know what you think? And making sure you're working together as a team is the best advice that I have.
Wonderful. Thank you so much. And thank you to everybody for coming tonight and spending your time and energy learning more about this disease and educating yourself to be a better advocate in all the different spaces. So thank you all for coming and joining us. And thank you to Dr. Sharp for this amazing presentation. Again, for everybody, we will make the recording available. We have a new video library up on our website, so you can always check back there if you missed the email, which does sometimes happen through Eventbrite. But make sure that you can get it anytime and rewatch it at your leisure. So again, thank you so much, Dr. Sharp. Have a wonderful evening, everybody.